Hello, I'm Kaylee Usher from the University of Western Australia and founder of the International Arthrofibrosis Association. I'd like to welcome Professor Ingrid Klintberg from the University of Gothenburg, Sweden today. Thank you very much for joining us. Our topic today is going to be local cryotherapy or icing and how that can help people with arthrofibrosis. So I'll begin with a little bit of a background for people who are not aware of what arthrofibrosis is. It's a painful and stiff joint, basically, and it can affect any joint. And it's known by a whole lot of names, including stiff knee, frozen shoulder, adhesive capsulitis, stiff elbow. There are quite a few different names, which kind of complicates the picture. But the main symptoms are pain and stiffness in the joint. And it can affect any joint and people of any age. And it's actually quite common after a joint injury or surgery. So it can have a very severe impact on people's lives. And there are no guaranteed cures and very few treatments, in fact. So anything that we can do to help our joint and keep it happy is well worth doing. So, Professor Klintberg, can you please tell us a little bit about yourself and your background?
So, hello everyone. I'm a physiotherapist, clinically active at the Sahlgrenska University Hospital, and I was diplomed as a physiotherapist in 1982. Mainly, I work on upper limb and especially on complicated injuries post-surgically for the shoulder, but also a lot on elbows. And I also have been a teacher at the university, and I do some research in the domain of shoulders.
Excellent, thank you. And you are also lead author of an excellent review paper about local cryotherapy, which I might refer to as icing, just to keep things simple. So can you please tell us, does icing reduce pain?
Yes, that is our clinical experience, and it has also been supported that it does reduce the speed of nerve conduction and thereby relieving pain. And it also can reduce the muscle spasm, a muscle spasm that secondarily can lead to pain.
Okay, that's very interesting. And I guess if it's reducing nerve conduction, it's probably reducing the factors that nerves produce in response to pain, like substance P, which are also pro-inflammatory.
Exactly.
Yeah. So do we know much about how the body and the immune system are affected by icing?
There are a few studies, absolutely, and I'm not a physiologist, a pain physiologist or so, but I can report to you what we found when we read these articles, and especially one from a Swedish team from the Karolinska Institute, Stålgren et al., and who shows that the anti-inflammatory effect that cooling can change the tissue from a hyper-metabolic state where the tissue demands a lot of oxygen to a more normally metabolic state where there is enough of oxygen to ensure tissue viability. So,
okay.
And this is a very important information because I think some of our surgeons think that it might reduce the healing effect, but eventually it is the inverse. But it is also how we use cryotherapy. It's just not cryotherapy.
So by reducing that revved up metabolism, you're kind of taking the heat out of the system quite literally, I guess, and allowing a healthy healing rather than a dysregulated state. Very interesting.
Yes. Mm-hmm.
Yeah.
And that's also our clinical experience. Mm-hmm.
So some people worry that that icing can reduce blood flow by too much and create a state of low oxygen, hypoxia. Has that been your experience at all?
No, it is not. And that is the driver for why we did this review. Previously, the orthopedic ward was primarily at another hospital, and the way of doing things there, and we had also surgeons who did research on cooling on the knee, and we regularly used ice post-operatively. But when the ward was moved, the hospitals in Gothenburg were merged. At this hospital, it was a very strong thought among the surgeons that cryotherapy can do nothing else but harm. So they said it is absolutely forbidden at this hospital.
Oh dear.
And then we said, this is very strange, and you cannot say that without having this statement supported. And so we decided we have to do, physiotherapists, we have to do this systematic review to verify what is the body of evidence for or against.
Excellent. And you came out for icing?
Yeah, there is no evidence against. That is.
Excellent. So how soon after surgery or injury would you recommend icing starts?
Before the patient wakes up from the surgical procedure. When they leave the surgical theater, today, an ice pad is placed on shoulders, on knees, and on ankles regularly.
Okay.
And we have also developed icing for elbows, but unfortunately, that is used less often.
So it doesn't matter what equipment you use, how you apply the ice, the cooling?
We have a very, very simple device, but it is put into unfortunately, perhaps I should have brought one to show you. But it's just put in a non-woven 2 pockets and that you fold the pockets. Into the pockets you put 2, cassettes with just water that has been in the freezer. So it's very simple, not expensive equipment at all. I think it costs $10 US or something like that.
Wow. Okay.
So
very good.
Nothing fancy, but it's easy for patients to apply, and it can stay on, so they can move around with the icing on them if so preferred.
Okay, that's useful. Yep. And if they don't have something a little bit fancy like that, maybe they can just resort to the old gel pack or even frozen peas.
Exactly, frozen peas are excellent. Anything goes.
And how long would you recommend people ice for?
So where they wake up after surgery, they can change these these cassettes with the iced water, so they keep this on until they are awake. But when most of the time, the majority of our surgical procedures, patients leave the day of surgery, even for major surgery, or the day after surgery. And what we recommend is 10 to 20 minutes. So when they remove the cooling device, it is still fully frozen. And here is the effect of the hunting effect. So we want to cool down to have this vasoconstriction, and when you remove after the cooling, we want a fully vasodilatation. So there is a blood flow, and enhanced blood flow through the system or the operated region.
Okay.
Removing
kind of
dead cells
flushing.
that might attract water. So thereby not letting the swelling coming into the joint, but to remove some of the reactions, post-operative reactions that would lead to swelling. Yeah, so 10
terrific.
to 20 minutes. And we also say, if it's not comfortable, you remove it earlier. So regions of the body where with less soft tissue protection, you should be a little bit more cautious.
Okay.
But we say you use it according to your comfort.
Okay, terrific.
But not longer than 20 minutes, because we want to have this effect of the rapid opening of all the blood flow, the what do you say, the veins and the arteries.
Yeah.
So there is a flush through the system.
And that would reduce swelling as well, I imagine.
Yeah. And for a very anecdotal point of view, we here in Sweden, you know, where we can have -20, -30 degrees, and if you are out for a walk, you will cool your cheeks, and you can see when you come in, you can be almost white. The blood vessels have closed down. The blood goes into the center of your body, but after just 1 or 2 minutes, your cheeks will be flushing red, and you can really feel this flushing through. So
okay. Very different to our.
We do not need rocket science or thorough research to know this effect.
For sure, yeah. And in your experience, do you think icing can improve range of motion?
Yes, I think so. So in a tight joint, if we reduce swelling, then it will be easier to move. And if we reduce pain, it will be easier to move. And also, if people, the icing is so easy for patients to apply, it enhances, what do you say, self-efficacy. And also this self-efficacy that they can regulate and treat themselves. I think that gives a certain self-confidence, and that also improves. That I can test myself. Self-management.
For sure. Yeah.
One part of it. We can add several small parts and as a sum. But I would not say that icing is the treatment to improve range of motion, but together with other things.
Sure. Stretching, etc.
Also, perhaps if we say that if and also in the hand, if you reduce the swelling, then you can start using your hand, and then the motions will reduce the further on the swelling, and you are in a more positive loop.
So how long do these effects last for?
It depends, but perhaps 1 hour, 1 hour, 2 hours, 3 hours. We did also a randomized clinical trial for patients who had elbow surgery, including elbow surgery for arthrofibrosis, to regain range of motion. And it could be that patient said that up to 4 and 6 hours.
Wow.
But we often say, think it as if you took a paracetamol.
That's an interesting analogy, yeah.
You do not expect more than a paracetamol. So you will have a few hours of a more pain-free state.
Interesting.
And in this study, patients could apply cryotherapy, or we asked them to apply cryotherapy 4 times per day.
Okay, yep. So some hours between each session.
Mhm.
Yep. Hmm.
And we often prescribe also paracetamol or NSAIDs after acute injury or so.
So you mentioned before that people should do it according to their own comfort level. Some people, particularly people with arthrofibrosis, have some nerve damage and cold intolerance. Can you tell us a little bit about that?
So that is very interesting because, as I said, the majority of patients in this elbow cryotherapy study, the randomized clinical trial, unfortunately, it has not been published. There was one patient who had the surgery for arthrofibrosis, and he did not like the cold. He did. So he was
Yep.
the only one who said it increased my pain, and especially
Yes.
the 48 hours after surgery. So his
Okay. Yep.
result differed completely from what the other patients where the surgical procedure had another background or for other would you say injuries or causes.
Sure. So yeah, a nerve injury. Yeah. Okay, that's interesting. So in that situation, it could actually have a negative effect rather than a
Yeah,
positive effect.
or if they are already so sensitized, they have a higher level of sensitization. Is that correct to say that? That is also
Yeah.
my feeling. Uh,
Yes.
So
Yeah.
also
Okay.
from what he said, really, we can say there is all we can be sure that if you use it with caution, um, there is no risk with cryotherapy. But if you don't like it, don't use it.
Sure. And can it be used for other joint conditions, like chronic joint arthritis, perhaps?
Yeah, yeah.
Yep.
So in the study, we had several for arthrosis, knee arthrosis, so that it is these studies that show that also in long-term pain, range of motion can be increased, and they also think that this is the pain, the muscle spasm, pain leading to muscle spasm, reducing the pain and the muscle spasm will give a better range of motion, and also bringing in the patient to a positive loop. If they start to move, point they will regain motion and
Move the
all the positive effects that physiotherapy is founded on. Motion
yes.
is the best therapy for all joints.
Yes. I'm a big believer in motion.
Good. So
So
sometimes I think that you can use the term that it's like a glass of champagne before a party. So it is a start. Often it is used and described that should be used after therapy. So you have your intervention, physiotherapy invention, and then you use cryotherapy or icing afterwards. But here, if a patient calls me and says, "Oh, Ingrid, I cannot come for therapy today. I am in such pain," then I say, "Come," and we start with cryotherapy, and then we do the exercises. So I ask them often to tell me how much in pain are you in now when we start, and then I ask again when they leave. And I would say, to my experience, 100% of times, there is less pain when they leave than when they come. So
very
it can
interesting.
also 10
Yeah.
minutes of icing before, and then do your home training program, or we expand eventually here, and and then gradually the pain level decreases. So it's a starter, facilitator to do the rest of the things that physiotherapy is founded on. Yeah.
Very good. Thank you. I have a from a patient and a question from a physiotherapist. We've covered both of these topics a little bit, but I'll read them out. From the patient, ice is my best friend. For me, it's the most effective way to get a pain flare under control. Ice is so soothing. If I wanted to, I could easily leave ice on my knee for hours. So my question would be, at what point does icing go from being effective to being detrimental, if at all? Is there a time limit? 20 minutes, 40 minutes?
Yeah, so I would recommend 20 minutes and then leave it for a few hours, 20 minutes and leave it for a few hours. And I do not have any evidence that it could be detrimental to have more than 4 applications
in a day.
during the day and night. And why not putting on ice 20 minutes before you go to sleep, and so that you go to sleep in a lower state of pain or discomfort and so on. Yeah. And so one of the questions in this randomized trial was, if you were going through the same procedure again, would you use cryotherapy? And also, if a relative or a friend was about to have the same surgery or procedure that you have had, would you recommend them to use cryotherapy? And exactly the majority said exactly like this patient, that they liked it and that they would recommend it and they would use it again.
Okay, yeah, that's useful.
And some were can help, if it cannot, but yeah, some had rather a strong positive feeling.
Yes, I can understand that. So a question from a very experienced physiotherapist. Can you give a quick guide to a quick and effective way to understand when icing does more harm than help due to subclinical peripheral neuropathy, which is like the cold hypersensitivity, I guess, that we were talking about?
So do we talk about patients who does not have full sensation? Or
maybe, yeah. How do we know when it might be detrimental? But yes, I guess if they don't have full sensation, that would be another category I hadn't thought of.
Yeah, and then I would be cautious, or really having a clock to say that after 10 minutes, move it. So there's a really signal for the patient. Now you should remove it, and perhaps you have verified that you cannot see that there can be any superficial signs of anything doing harm. But I really try to learn the patient to listen to what their body tells them. It is not me, it is not the surgeon, it is your body. Think that your body and the structures, they are your best friend, and you should have, they want you will treat them so that they will hang out with you. So really listen, and if you can do that, then it can't be of any harm.
I think that's excellent advice.
Okay.
Yes.
Thank you.
So the quick and effective guide would be, if it feels bad, don't do it, I guess.
Exactly.
If it feels good, do it.
The KISS principle.
Yes.
Yeah.
Hmm.
So in some of these articles or papers, there were adverse events, but some of these were not attributed to the cryotherapy, but to the primary intervention. And also, if you what do you say, malpractice.
And I guess on that,
if you put an ice block directly on the patella, but of course that can give a frostbite. So don't do that. buy a package of frozen peas and put a towel, and not a wet towel, but a dry towel closest to where you want to apply your ice, and then the ice on. And remove it after 10, 15, 20 minutes or before that if it's uncomfortable. And early after surgery, perhaps the structures and the tissue is more stressed, under stress, and you can longer the application time. But
Okay.
always according to your own discretion, according to your own decision
Feeling.
making. Feeling.
Feedback from the body.
Feedback from the body.
Very
Exactly.
good. Okay, well, thank you. I think we've pretty much covered that topic very well. Really appreciate your time. Thank you.
Thank you. And I'm interested of your research and your work on arthrofibrosis. For this is really an would you say an enigma?
Certainly a
Where,
very complex area of immunology. That's
yes. And up to date, I don't think anyone really knows what this is all about.
Yes. Yeah, it's so complex. There are so many different interactions and pathways that can all feed into it. So a lot of research to be done.
A lot of research to be done.
Yes, yes. And hopefully the first real advance we'll make is in being able to image myofibroblasts with PET CT and be able to see what effects these therapies have directly on the myofibroblasts that make fibrosis.
Good.
Yeah.
Do we have questions for me to ask you something?
Yeah. Well, if you wish to.
So I have worked with Karen Jin, professor of physiotherapy and at the medical school in Sydney, and she has done research to show that some of the reduced range of motion is really from a muscle spasm. So when you put the patient under anesthesia, sometimes quite a lot of range of motion can be gained. So it's not really stiff architectural, but a muscle protection. And with her research team, we discussed eventually if giving a support to help the muscles to relax in between boots of regaining range of motion, perhaps will increase the gain of range of motion. To date, everybody talks so that you should move. And eventually, according to my clinical experience in other conditions, I think that might stress. And I would.
Yes.
So what is your clinical?
That's our experience as well. And I collaborate, the International Arthrofibrosis Association is a collaboration. We have a very experienced physiotherapist in Switzerland, Sebastiano Notarelli. And that's his thoughts and my thoughts as well. And also a lot of experience from patients in that active exercise can be very detrimental when it's highly inflamed. But passive motion is crucial. So I strongly advocate for continuous passive motion. And the more inflammation there is, the more that needs to be done. So twice a week isn't going to cut it if it's early post-op. It needs to be continual and in the pain-free zone, because if you're stimulating more pain, then you're stimulating more inflammation. So lots of pain-free CPM.
Oh, perfect. Thank you for that. I will pass that on to our surgeons, who sometimes say it demands a tough physio who really can push. And I say no.
Pushing through pain is, I think, about the worst thing you can do.
Thank you. Thank you.
Yeah.
Thank you.
Nerves are very much a part of this pathology. And so if you're stimulating the release of substance P and all the other substances from aggravated nerves, then you're stimulating inflammation and you're stimulating fibrosis.
Exactly. Very good. Excellent. Excellent, excellent.
Well,
Perfect.
thank you for the question.
You're welcome. Thank you.
Yeah. And I appreciate your time.
Thank you. Likewise.